In the next few slides, we'll be looking at common complications associated with regional anesthesia, and as we know, the regional anesthesia techniques will achieve their outcomes by the utilization and use of local anesthetic agents. Complications of regional anesthesia may include muscle paralysis and eventually the compromise of the ventilation process, and this is due to the higher block affecting the respiration process by affecting the respiratory muscles and eventually ventilation due to the spread of the block higher or cephalically, where the center that regulates respiration muscles and ventilation processes could be anesthetized. Overall, when we look at the profile of safety for regional anesthesia, they have been shown by multiple systematic studies that it reduces mortality and also it reduces serious complications post-operatively. However, pain could still be one of those risks associated as a complication with regional anesthesia, that it may not be resolved, and it could be as high as 1 in 4 patients experiencing some type of pain. Postdural headaches due to CSF leak may be a complication, and blockade of the sympathetic nervous system with the neuroaxial techniques could also result in mild to severe hypotension and bradycardia that could clinically be significant. This is more so in patients with cardiac history, that the slight deviation from the sympathetic nervous system blockade would result into mild hypotensive and bradycardic episodes, which could translate into a clinically significant event for that patient if they have got. If we summarize the serious complications of local anesthetics or regional anesthetics, it would include potential bleeding due to the epidural or spinal technique, having a higher block because of the rapid spread of the local anesthetic agents causing respiratory failure and respiratory compromise, potential nerve damage, and because of the blockade it creates and the vasodilation that would entail, the shifting of blood volume may also carry the heat with it, and then it may induce hypothermia. Spinal cord damage is a potential risk that could be transient or it could be permanent based on the size of the affliction or the damage. It could cause spinal infarctions. It may introduce infections if proper aseptic techniques are not adhered to. Formation of hematomas again would translate into nerve damage and some form of compromise to the functioning of the nerves. Reactions to the medication agents may lead to anaphylaxis, and also urinary retention being one of the common causes with the neuroaxial techniques. Postdural puncture and its associated headaches could be commonly seen in obstetric adult patients. This is due to the CSF leak that results from the puncture site after a neuroaxial technique of spinal. It could be more common with larger bore needles because of the mechanical association with a larger gauge needle and a bigger hole, and then more loss of the CSF. With the pencil-tipped needles, this seems to be occurring less, and those type of needles have got a higher or a larger safety margin. The symptoms could be headaches, photophobia, nausea and vomiting, and dizziness. And this sort of headache may not be rectified by positioning, and typical treatment strategy would be analgesia, hydration, and epidural blood patch, where patient's IV blood's been acquired, and then that could be given into the epidural space, so the clot that would eventually form is hoped and anticipated to plug that hole for further loss of CSF. Total spinal blockade with the use of local anesthetics could be seen as a potential and a very significant risk. This is when inadvertent large amount of local anesthetics has been injected into the spinal cord, and that could move cephalically towards the head. That would affect sensory levels and paralyze muscles, and that could in turn affect the respiratory function and ventilation and gas exchange. In severe cases, it could also cause unconsciousness. So the treatment and management is through the traditional ABC techniques of maintaining the airway, by whether it's requiring intubation and ventilation, and breathing, and then circulatory parameters would be assessed and rectified and managed accordingly. Of particular note here is that the closer to the respiratory centers the local anesthetics with potential high doses make their way, the more severe the risk would be. As an example, local anesthetics injected for the eye blocks, where they are in a close proximity, and if there's a mismatch of dosage and calculation for the patient's requirements, then that would translate in this potential risk eventuating at a higher level. Hypotension is seemingly one of the most common causes that we see from day-to-day basis. Approximately 1 in 2 patients, they will have a transient phase of hypotensive episode, and this is due to the sympathetic nerve blockade as soon as the regional technique takes effect. So to rectify the issue, and in this case there is no obvious fluid loss as in out of the patient's body. However, the compartments within which the fluids exist, they will make a shift, where with vasodilation below the level of the sympathetic blockade, you would have this more storage space suddenly created, where the existing blood volume will shift and go into a larger space. So to rectify this scenario, the use of crystalloids and colloids would be highly indicated, and also from a pharmacological point of view, they would use vasopressors such as ephedrine. And this needs to be through a thorough assessment or case by case based on the patient's need, and it highlights the importance of IV access, for example, because of the patient's need, that this hypotensive episode would be quite sudden, and the management of it would require immediate interventions. And this signifies how the assessment or patient selection process for regional techniques is as important as the general anesthesia techniques. Other complications of regional anesthesia techniques at the neuroaxial level may include the cauda equina syndrome. It could be a transient or permanent. It is a rare condition, and that is when the lumbar plexus nerve roots could be damaged due to a traumatic injury at that level of the spinal cord. Also, adhesive arachnoiditis. This can occur even weeks later after the procedure, and that's due to the meninges proliferating, and then by doing that they could cause vasoconstriction of some of the small blood vessels to the spinal cord. As we know and appreciate the anatomy of spinal cord, it is a living entity and it needs its own blood supplies and lymphatics, and then if these meninges basically grow where they are impinging on these small little blood vessels that would actually provide oxygen and nutrition to the site of the spinal cord, by compromising those areas, the sensory and motor functions would manifest as deficits eventually. So this form of ischemia and infarction to the spinal cord would also be noted later on, and this is one of the areas where, based on history of the technique, some patients may refuse local anesthetic technique part of their care. And finally, we would like to list some of the major complications to do with the use of local anesthetic agents as specific blocks. As we know, part of a multimodal pain management mechanisms, local anesthetics could be used as part of a regional technique, and then we could still have the risk or the potential for complications of unresolved pain. There might be risks of bleeding and hematoma, especially due to the intra-arterial introduction of the needle to the site, or it could be nerve injury by accidental injection into the nerve bundle. Introducing needles from outside could potentially introduce infection to the site, and then with bleeding and compromising the blood flow to the area, we might also cause ischemia and even necrosis. So overall, these complications are quite rare. The techniques of regional approaches are gaining more popularity, and they are increasing their safety parameters, especially with the use of ultrasound guided needles and ultrasound guided approaches. There is higher level of safety involved with these techniques. However, we need to be vigilantly monitoring for these things. From a nursing point of view, when we think about, okay, we have identified these risks, now what we can do is, in terms of a rigorous assessment post-operatively in the time intervals that are required, if procedures involve certain blockades or nerve blocks or regional techniques, we need to undertake specific, for example, neuroobs on a certain limb where they had a local anesthetic injected specifically for a nerve. We need to do the neurological obs with the frequency required, and this also needs to be reflected in the documentation we are providing as part of that episode of care.